Hi everyone, I'm Tessa Cook from the University of Pennsylvania, and I'm delighted to join you here for the Society for Magnetic Resonance Angiography meeting to talk about the promise and potential impact of AI in clinical practice. I have some disclosures, most of which relate to leadership roles that I hold in various radiology organizations. I have some grant funding, and my department has some vendor agreements surrounding AI research. What I wanted to share with you today were some opportunities for AI to augment the clinical workflow, particularly as it pertains to the performance and interpretation of MR angiography. We'll also talk about some of the challenges associated with deploying AI in clinical practice. So I went to the literature to look at the current state of AI for MR angiography. And most of what I found was actually focused on MRA for intracranial vessels, and in particular for automated detection of cerebral aneurysms. So there were a number of papers on this topic. A couple of them were actually larger studies. You can see here almost 700 patients in this radiology paper on deep learning for automated detection of cerebral aneurysms. Another study, almost 600 patients, looking again at intracranial aneurysm detection. And then a smaller study looking at aneurysm detection using 3D time of flight. And then I also found a number of smaller studies. A few of them actually focused on image reconstruction. So here, actually using 5 acquired images to then apply deep learning and generate the entire MR angiogram, and with equivalent results to time of flight imaging. Another fairly small study on deep learning-based arterial spin labeling. And one study looking at reconstruction of case-based data for thoracic aortic MRA and comparing the conventional approach to a GPU-driven approach using deep learning. Again, all relatively small studies. And a couple of studies looking at coronary MR angiography, here various model configurations looking at improving the speed and the image quality that resulted with reconstructions done with neural networks. And then a small study looking at non-contrast coronary MRA and deep learning reconstruction for that. And so if we look at the current state of AI tools for MR angiography and consider potential areas where AI could play a role, I find it useful to actually think about my current approach to interpretation of MRA. And I find this generally is useful for any kind of study type, but since we're talking about MRA, I'm going to use that as an example in this case. So the process generally begins with waiting for the images to be acquired and the exam to be completed. And either in parallel or subsequently, we always have to do some sort of investigation of the medical record to determine why the patient is coming for imaging and what the clinical question is that we need to answer. Oftentimes we have to review prior studies to look and see what findings were identified on those examinations, what it is we may be being asked to follow up on this exam, and then actually review the dozen or sometimes multiple dozens of series that were acquired and generate an interpretation. And that interpretation, depending on the body part that we're looking at, involves looking at the salient vessels, doing necessary measurements, comparing to the prior study, making note of any significant changes that might affect patient management, and of course reviewing and interpreting all of the non-vascular findings, and in some cases picking up the phone to alert the ordering physician of any unexpected changes that we identified on the exam. And so as I went through that narrative, you probably realized that I didn't ever mention AI because we're not currently using it for interpretation of MR angiography. And in fairness, I should say that I am a cardiovascular radiologist in a practice that draws a line at the clavicles. So everything above the clavicles goes to my colleagues in neuroradiology, and everything below the clavicles that has to do with a blood vessel comes to us. So admittedly, as we've seen in the literature, there are some preclinical applications of AI for intracranial MRA. And so, again, just reviewing what we found in the current state, there certainly does seem to be a focus on intracranial imaging, particularly for diagnosis, specifically looking at intracranial aneurysms. The patient cohorts, with a couple of exceptions, as I showed you earlier, tend to be small. And the applications, although there are examples both of image reconstruction and findings detection, it does actually skew a little bit towards the former in terms of the number of papers that are out there. And again, I should clarify that this is for the peer-reviewed literature, not the preprint literature. And so there may be a lot of work in the preprint stage that is not represented here. However, that still gives us the opportunity to think about where MRA could benefit from AI technologies. And certainly expanding to other body regions is one obvious instance. We do a lot of imaging not only of the thoracic and abdominal aorta, but in our practice here of both the upper and lower extremities for peripheral arterial disease in the lower extremities, for vasculitides, for surgical planning in the upper extremities. And there are certainly opportunities for application of AI in those body regions as well. The patient cohorts that we saw in the literature that I showed you tend to be on the smaller side, with again a couple of exceptions of those larger studies. And I think for AI to really penetrate the clinical workflow for MRA, we're going to need some larger evaluations, and we're going to need many more instances of AI that can handle abnormal findings. And so what I didn't show you, particularly for the image reconstruction studies that I mentioned, was that for the most part they were studied and trained using healthy volunteers or normal exams, if you will, with a couple of cases with pathology in them. But really, for AI to have a meaningful clinical role, we're going to need to have tools that can handle studies with both obvious and subtle abnormal findings. And there are multiple potential applications and ways that we could use this technology, right? So findings detection is sort of an obvious one. And note that I don't call it interpretation because the AI is not strictly doing the interpretation. It is finding the abnormality and classifying it for us in some way. And it's really up to us to make the final interpretation. Measurements are one thing that could be very easily automated, and automated in a way that's probably more accurate than us as humans doing those measurements, and that can also then tie very nicely into quantification of interval change in disease, which is not something that we can automate as easily today. And then there are the things that we don't really have a good clinical equivalent for right now, including looking at primary and secondary image features and textures and starting to do radiomic analysis, particularly in our patient populations with connective tissue disease and vasculitides. There could be some real value that AI could bring in helping us with those particular patient populations. And also, I think one real mark that AI will leave on the future of clinical practice is in predictive analytics, is in being able to help us identify features of images that can actually change prognostic decision making and workup and management for patients. So not purely making the diagnoses, but identifying findings that could give us a sense of risk of future disease, disease progression, management strategies that may be more or less successful for that particular patient, given imaging findings that may or may not even be visible to the human eye, but maybe some of these texture-based features that I talked about. So I think there's a real opportunity both for very practical things like measurements, but also for sort of far-ranging and future applications like predictive analytics. Now, I do want to spend some time talking about challenges to successful clinical implementation of AI. And these are not necessarily specific to MR angiography. They have relevance both to pixel-based AI, so AI performed on images, but also AI performed on other types of data in an imaging practice. And when you think about deploying new technology, whether it's AI or something else, ideally it progresses in a nice, logical, straightforward fashion from the concept to the steps of the implementation to a production application that works seamlessly and has minimal downtime and doesn't require a lot of investigation or monitoring or intervention. That's the ideal world, right? Reality tends to be that systems have to interact with one another, have to communicate with one another, don't necessarily speak the same language, so to speak. And so putting in one of these systems, and particularly with AI, which may require continual feedback and learning, and may have to reside in the cloud, which requires security related clearances and delicate technical implementation, it may not always be so straightforward. It is certainly by no means impossible, but it takes a little extra work. But I also don't want to focus too much on the technical side of things here, because I think there are a lot of non-technical aspects of this to consider that can really make or break the success of the AI implementation in your practice. And a lot of this falls in one way or another under resistance to automation. And it perhaps is not so much even resistance to automation as lack of familiarity with new technology and a very reasonable need to understand how it works and what it does, and then by extension, how to incorporate it into the clinical workflow. Now, the big challenge, of course, with AI is the fact that it's perceived a little bit as a so-called black box, by which data goes in, something happens, a conclusion comes out, and it's not entirely clear how that conclusion was reached. There's a very nice consensus statement that I had the privilege of being a part of involving European and North American organizations and authors, both clinical and non-clinical in expertise, medical and non-medical, also including patient voices, looking at the ethics of AI in radiology, and this was published earlier this year. And it says that transparency, interpretability, and explainability are necessary to build patient and provider trust. And that makes sense. And I think that's true of any new technology that might ultimately be used for patient care, not just AI. But it is particularly important to consider for AI because the algorithms adapt to the data to which they're exposed, the model results, and the behavior of that model is not entirely always obvious. And to that end, there is a very active field within AI development and research focusing on something called XAI, or explainable AI. And the goal of explainable AI is to start to try to open up the black box and help us look inside, if you will, and to try to understand what parts of the data the model uses to make its conclusions. And so in this particular example, this is a normal chest radiograph here on the left, and the AI has chosen to predict it as belonging to a class of pneumonias. And it shows you in green the regions of the image that supported prediction of pneumonia, and in red the regions that went against that prediction. But the ultimate prediction was pneumonia. And so you get a little bit of a better sense of what the model is honing in on to make its decisions. But you also get the sense looking at this, and I agree, this is not an MR angiogram, but I wanted a nice example to show you what the technology looks like. You also get the sense that the AI is using a lot of the image that the radiologist might not be using to make a diagnosis of pneumonia or not pneumonia. And so this is the beginning of improving the way that radiologists receive this technology, is to open up that proverbial black box to help us understand a little bit better what the technology is honing in on, and also to help us then to appropriately use it in the context of patient care. Now, I'm not going to talk too much about the specific metrics that are used to judge AI performance and that are typically reported in the literature, but I will mention them. You'll often see terms like recall, precision, the F1 score, and the area under the curve. And all of those are derived from the conventional 2x2 matrix of true positives, false negatives, and true negatives. But it's always important to consider the performance of the AI from the perspective of how it impacts clinical decision making. So in some cases, such as if this was an AI to detect tension pneumothoraces, a false negative, in other words, an x-ray that had a tension pneumothorax, but was labeled as not having a tension pneumothorax and perhaps dropped to the bottom of the work list or lower down on the work list, could have really bad implications for the outcome of that particular patient. Now, if you think of the other end of the spectrum, where the model is so tuned to finding stenoses on an MR angiogram that it flags everything rather than just the plaques and the lesions that are going to be clinically significant. In that instance, you may have a radiologist just set the output of the tool aside entirely because it's not helping them with their clinical practice and their clinical decision making. And so the performance of the AI really has to be tuned to each specific use case. It's not a one-size-fits-all solution. Then there's the concern about accuracy and repeatability. And particularly as you think about the fact that we're trying to translate this technology from the proverbial bench to bedside, in other words, from the research lab to the clinical space. And these are technologies where the training data that the model is used to fine-tune and develop really make a difference in its performance. And so accuracy becomes very important, in other words, the number of correct answers that the model gets. And repeatability also becomes important because you want to be able to take an AI from the lab, put it in the clinical practice, and observe the same high level of performance that you observed in the lab. And there are a number of instances in the literature showing that that is not the case, that there are AI models that do very well in the environment in which they were trained, tested on separate data from the training data, but still in that similar environment, and then taken to a different environment where they don't perform as well. And so what can we do about that? Well, it brings up the concept of overfitting. And it is possible that those well-performing AIs, when they live in their native environment, were a little bit overfit to the data in that environment. And so the algorithm became very sensitive to aspects of that data, such that when it was presented with similar data, it did well, but when it was presented with different data, it did badly. And so what we want to do is not to necessarily to overfit to our data. If what we're trying to do is build AI that can do well in any environment. Now, that can be a real challenge because the training data has to be representative of all of the different kinds of exams that the AI might encounter. And so another way to look at this is to, in some ways, take advantage of overfitting and to take an AI model to further train it on data from the site where it will be used, effectively doing transfer learning, but some degree of intentional overfitting there, and then using it in that environment. And we're starting to see this as an option, even with the vendor community, taking their pre-existing, pre-trained models and then further training them on a customer's data to improve performance. Then there's an important thing to always think about as we talk about new technology, any new technology, but particularly AI, and bringing it into the clinical workflow and having it produce results that may not always agree with the human interpreter. And this brings up the concept of automation bias. So assuming that the AI is always more correct than the human. And we need to train radiologists when we are training them to use this technology, and also our future generations of radiologists who are going to be learning in an environment where AI is a little bit more native than it is now, to always think about what the expected outcome might be, particularly for things that we can validate and verify visually, and to not always assume that the computer is always right. And we also need to make sure that individuals that are either inexperienced with the technology or new to radiology are aware of the danger of automation bias and encourage them to not ignore their own clinical opinions. The other concern here is that inevitably what happens is that when an AI is first put into an environment, it performs really well, but as the data shifts with time, its performance may deteriorate. And that is just a natural phenomenon. But knowing that it happens means that we have to figure out some sort of quality control for the AI in order to make sure that we're monitoring its performance, and that should it make a mistake, and it may be a subtle mistake rather than an evident mistake, that we are able to detect it and give feedback to the system. And it's very important to remember, right? The goal is not to generate a robot radiologist. This is not what we're trying to do. There's so many ways that AI can actually improve our practice, whether it's by decreasing the amount of time that the patient has to be on the scanner, improving reconstruction of images, increasing measurement accuracy, because let's face it, the computer can do a better job of repeatedly and consistently measuring the same structure over time and doing that comparison for us. Decreasing repetitive tasks that are better automated than required of the radiologist, and improving reporting. And while I know I've talked a lot about AI that is pixel-based, my research interests actually are entirely in non-pixel-based AI. And I am waiting for someone to build an AI that will go through the medical record when I open up an exam, find all of the pieces of the medical record that are relevant to the patient and the indication that I am interpreting at that moment, find out all of the other workup that's been done. So for vascular imaging, have they had an echo? Have they had ankle brachial indices? Have they had conventional angiography? Have they had prior CT or MR angiography? And tee up all of that information for me, because I go through that search process myself, but it would be so much more efficient if the medical record had an AI that could do that for me. Because at the end of the day, what are we trying to do? We're trying to augment the expert physician reader. We're not trying to replace the expert physician reader. But we should really take advantage of the things that the machine can actually do better. A couple of practical considerations. Everything requires some sort of financing and funding. And so budgetary considerations are important. The return on investment is important. Until recently, I would have said, it's hard to quantify the return on investment because you could measure it in many different ways. Well, just last week, the Centers for Medicare and Medicaid Services, CMS, in the United States, chose to approve Another very important practical consideration is how you actually integrate the AI tools into the clinical workflow. There may be certain use cases where it's entirely sufficient to just send the AI results in static form back into the diagnostic viewer. But there may be other instances where it's important for the radiologist to be able to interact with the AI results and perhaps even take that one step further to have a sort of accept reject workflow where the radiologist can agree or disagree with the AI result, and then to have those agreements and disagreements actually fed back to the model to improve its performance. And so it's really not a one size fits all solution, and it's going to depend on the specific use case as to how the AI should be integrated into the workflow and how the radiologist should be able to interact with them. So, in conclusion, I hope that you've gotten a sense of the great potential for AI to impact the acquisition of images, performance of imaging, and then interpretation of imaging, specifically with respect to MR angiography, but even more broadly, and a better appreciation of the considerations that go into safely and responsibly deploying this technology in the clinical workflow, some of the challenges that we should be aware of going into it so that we can mitigate them, and also make sure that at the end of the day, we are responsible for delivering good patient care and making sure that this technology is used in a way that can do that. And I'm grateful to have had the opportunity to share this discussion with you, and I look forward to the interactive session during the meeting itself. Thank you so much.